Okay. All right, I think it is appropriate to now say good evening. and thank you. Thank you all. Oh, oops, I'm going to close that door because otherwise echo. Thank you all for joining us for the reconvening of the Insurance and Pharmaceuticals Subcommittee. We are going to take up House Bill, begin again with House Bill 912. You all provided a great deal of great feedback this morning, and I want to thank Lisa Simpson for her heroic efforts in trying to put together these ideas, and also some of the stakeholders who are working with her to bring, to try to bring these ideas together to make sure that we had this bill ready to move forward. So, and Delegate Krebs is, she's okay. So if you have the reprint for 912 with you, there are no changes on handwritten pages 2 and 3. The amendment on page 4, it was there originally. That is not a new amendment. Page 5, handwritten page 5 is not changed. So we get to handwritten page 6. And there were a couple of issues around the language on 29 to 32. And what we heard the committee say was that there needed to be some responsibility on the part of the consumer to reach out to the carrier to find a provider who was in the panel who was able to meet their needs. And if they weren't able to do that, then they would be able to seek to go out of network. And what you have received from Lisa at just recently, it's a notice. Do folks have this, or and I will go ahead and read it so that folks can respond to it, but hopefully you'll be able to pull it up on your website, on your email. It says each carrier shall have a system in place that documents all requests to obtain a referral to receive a covered service. Okay, that's already standard language or current language. And here's the change: inform members of the procedure to request a referral under paragraphs 1 of the subsection, and provide the information documented under item I of this paragraph to the commissioner on request. So that is the language that we're recommending to replace lines 29 to 32. So folks are getting the procedure to request informed in all the ways in which the carrier communicates with the consumer. I've been told that the provider panels are listed in the provider panels are listed in the provider directory that folks have. So thoughts on this amendment here? Ellen.
Thanks. Thank you very much, Delegate Cullison, and thank you, Lisa, for the revision. I think it's very important for consumers to know the process, and so that is helpful. We still, I think, have the same concern about the existing language to provide notice of the actual right in plain language. Would still supplement this tremendously. So people will understand that they have this right, and that they then will know that there's a process for requesting a referral. So that would be, again, I don't understand. I guess my question is what is the reason for not providing just, again, that notification of the existence of the right?
Okay.
Language?
Okay. I'm going to go to Kim Robinson to respond specifically to that question.
Thank you, Delegate Collison, and thanks for the question, Ms. Weber. So I think there's a little bit of a disconnect for what you think this is say and the way we read this. So one, this is consistent with the kind of notice that's happening in other states. So I know this language happens to be.
Oh,
I don't know
hold on, we gotta.
Coming from, yeah.
Yeah, hold on. I think it's the hallway out here. Hang on.
You got it,
Okay.
Delegate. So the language I know mirrors the handful of states that do have a notice around this particular law. The place we would give it is going to be in consumer communications, which is always going to be in consumer understandable language. So I don't know why there's this feeling like if it doesn't say in plain language that somehow that's not what it would be. That's exactly where we want to put it. We want to put it in consumer facing documents. The reason why we were concerned with plan documents is because while they go to consumers, those are the legal binding contracts which need legal contract language. Do you know what I mean? And
Yeah.
so we didn't want to have to try to put more colloquial language in formal docs. And so to us, this language says we need to do something more proactive to make sure people know that the process exists. It would naturally go in something consumer facing. But for different carriers and different plans, it kind of works out better in different places. And I say that as a carrier, for instance, who's not in an individual market. And so how I would talk to, well, at least not in Maryland, how I talk to my individual clients is different than how I talk to my employer clients. And so there are different communications we use, and this allows the flexibility to put it in the right place, but it's going to be something consumer facing. It's going to potentially be consumer friendly in terms of how it's described.
Kim, I'm gonna use a little license here. I think the question is, would there be an objection to adding after the word procedure and right, inform members of the procedure and the right to request a referral?
So I guess we got a little hung up on the term right. That's not a typical use of language anywhere in the insurance article for any mandate. This entire statute talks about itself as a procedure. The word right doesn't exist in the statute. So it would be in some ways creating a designation of this as a health insurance right in a world where we don't have health insurance rights. And so I guess that for us, from how we interpret the statute, was a little concerning. I mean, I don't know that I think it actually is creating a difference per se, but we know that, you know, if a law goes to court and you say it differently here than you say it someplace else, it means something to a judge. And so we weren't really clear why this had to be specifically called a right. The law gives this to consumers, and the way we execute it is the procedure, like we do anything else the insurance article calls us to do. So that distinction, especially in a statute that's now picking out a small set of consumers out of a big pile of consumers, seemed kind of extreme in terms of terminology. So that's why I think it was a concern to carriers.
Okay, I'm going to turn to Matt Celentano.
Thanks,
Did you want to respond to the same question, or did you have something else? Okay.
I just wanted to, I'll be very brief. I just wanted to point out that the language that you're seeing in the amendment, the informed members language, is directly taken from the document Ms. Weber shared with the committee from 2 other states that have worked on this bill. So we didn't try to make up a new world. We were just using language that was provided to the committee from Ms. Weber.
Okay, thank you. All right, I'm going to go to Pat O'Connor first, because Pat is still connecting, so I won't go to her first. I'll go to Dr. Berman first.
Hi, thank you, Madam Chair. So my concern would be that consumers would know there is a process to request a referral, but they don't know that if they request a referral, then carriers would be required to abide by their request under certain circumstances. My concern would be that consumers would see this and say, fine, I can request a referral, but the big insurance company can always say no. So why should I request a referral? So it seems to me that it'd be helpful to let them know you can request a referral, and not only request it, but that carriers are required to comply with the request under certain circumstances.
Okay,
Thank you.
thank you. Pat, are you on now? Pat O'Connor? Pat? Not yet. Okay. Ellen Weber.
I wanted to, again, thank you. So I guess the key here is, in terms of the documents that you're going to put this in, to say that, to have a sort of, we just have to not have some specificity about where these are going to go is really the issue. To say that it be consumer facing, we can agree within this meeting to talk about that, but unless it's written on the paper as to where somebody's going to find this and where people are going to be able to go to look for it, we still have a concern that you're not articulating where that information is going to be provided. We appreciate it's going to be in a consumer facing document, and that's important, but isn't there some language that can be used to articulate that? That's really a concern. And then the other issue is, the right exists already in law. We're simply referring back to the ability to request that they have the so-called right that exists in D1. That's what we're trying to refer to. So it's not creating a new right. It's not establishing something that doesn't already exist in law. And so we think that it could have some connection in that way.
If it already exists in law, though, why do we need to state it here?
Because what we're trying to do is we're trying to make sure that the consumer knows about this. This right has existed for many, many years, and individual consumers do not know that it exists. It has been included in materials that we've talked earlier today are not consumer friendly. They're not in plain language. There has been this process that carriers have already shared with the MIA over the past few years, but none of that is publicly available, or the public is not aware of it. So what we're trying to do is just to boost that so folks can really exercise their rights.
Okay, I'm going to go to Kimberly Robinson again, and then we're going to see if we can move on here.
Thank you, Delegate Collison. So just to be clear, I wasn't saying that this was creating a new right. I think it's unusual to describe anything in the insurance article as a right. I don't know if you were to search that word, you're going to find that as describing all of the mandates and all of the various things that consumers are bestowed with as how we are to execute our business with them. And so it just was an odd way to single this out and use unusual language. There's a lot of language that we cleaned up that I just sent suggestions to Lisa to, just because a lot of the words that were used were not appropriate for the insurance article, right? So for instance, it made sure to use the term members because that's the defined term in this statute versus insured or something else. So there's the drafter in me, I think, reacted on some level to that. I think that when we talk about what we have to include, I think there's also a misunderstanding of what that would look like. It's not to say, if you want a referral, you can call us. The whole procedure is cross-referenced in subsection D, which is all of its moving parts, and its why, which includes because a provider is not available with the expertise or the expertise in the right time or travel. So all of that is the procedure. It's not, we aren't, I'm not to put words in his mouth. I don't expect Mr. Cooney to let us pick and choose which pieces of that we were to include. The entire thing is the procedure. And so I think that there's a little bit of a disconnect about how this works. This is not unusual. We do this under notice requirements throughout the insurance article. So I suppose we're looking through it through the lens of how this works routinely.
Okay. I am going to offer that the language here gets to the goal of making sure that the public knows that that there is a procedure that they need to follow in order to request a referral, and that this language implies that it's in communications that come from the carrier. I think, we have the main goal of this bill established in the language around holding the members harmless. So, now we're just, we're wordsmithing, but I don't want us to get hung up on words that will make this bill difficult to pass. And if folks can live with, inform of the procedure to request the referral, and folks do know that they can make a complaint to the insurance commissioner. So at least my constituents know that. So I think that, unless there is a burning desire on the part of some member of the committee to add the word right, or to add the specificity around the documents that this must be included in, we're going to move on from here. Okay. I am not seeing any committee members raise their hands. So, all right, then I want to go to the next section over which we had an issue. It is not prudent to set fees. We all know, and if those of us who live in the Insurance and Pharmaceuticals Subcommittee know that a big part of pricing insurance is about the ability of carriers to negotiate. And so it is a balance between, keeping the providers whole, but also keeping premiums at a rate. When you set fees, that is always going to be the fee. So you can't negotiate it. So we can't revisit. I would recommend that we not revisit that section. There was a request from the Speaker Pro Tem that we add information about an MIA report on the impact of reimbursement and the process and procedures for credentialing. And I have heard from MIA, and I think Dave Cooney is here, that is already being done, correct? It's being done, and there's a report due, if I'm understanding correctly, a report due in January of 2023 and another report due in January of 2025. Am I correct in that?
So the dates weren't correct, but thank you, Delegate. Yes, this is along with the mental health parity reporting bill that the legislature passed 2 years ago. So as part of that, we have to do an interim report, which is actually due in December of 2023, and then a final report in December of 2025. And we have to report on all our findings there. And it's important to note that 2 of the non-quantitative treatment limitations that are specifically identified on the reporting forms that all the carriers have to send in, one of them is credentialing, and another one is provider reimbursement. And we actually even have separate data supplement forms for each of those 2 items. We're requesting specific data from the company. So we will be collecting certain information on that anyway, and we are already required to report our findings to the General Assembly, like I said, the interim report and the final report.
Okay, all right. Ellen? Oh, wait, excuse me, Ellen. The Speaker Pro Tem.
Thank you, Madam Chair, and Mr. Cooney. So does that also include a timeline of showing how long it may take for a carrier to get a provider into the network? Is that a yes?
Yes, the credentialing data supplement is published publicly on our website, and there's a variety of things comparing medical, surgical to the mental health and substance use disorder facilities and practitioners. And it includes timing from when the application is submitted until a contract is executed. It actually goes in a lot more detail than that also. But yes, the timing is part of that study.
And then my last question for you, what does it capture at all? What things are being covered? What codes, specific codes are being covered? Reason I ask is because one provider stated that they were obligated for certain codes, but the carrier didn't cover that as a part of their agreement. Is that too in-depth or another subject? I was just curious, how much will we get out of this report?
Sure. That's probably too in-depth for the report, but if I'm understanding that correctly, that in and of itself could be a non-quantitative treatment limitation, which would have to be reported separately anyway. So I mean, if we actually identified an issue there, that would be included in the report. But that specific level of granularity is not one of the items we are expressly looking at.
So, David, let me ask as a follow-up, if you don't mind. But that would be something that a provider could reach out to MIA about and
Yes,
say,
absolutely.
you know, I've been trying to be credentialed by a carrier and they have put up barriers and loopholes and paperwork in front of me. Is that reasonable?
Yes, that's correct.
Okay. Okay, Ellen?
Thank you, Delegate Cullison. There are actually 2 points. There was one that I wanted to make with regard to what Mr. Cooney has just said, but then your comment with regard to rate setting and deleting those sections. I understand entirely why we're doing that, but part of what has also been deleted is this issue that would have required the carriers to enter into the timely single case agreements. And the problem that we have here is we now.
Oh, Ellen, your audio just went, Ellen.
Sorry, I'm back.
Yeah.
Thank you. There's nothing that will really, tie the hands of put in place time limits. So those negotiations, which would have been expedited by a reimbursement rate formula, will now potentially be protracted. And so we would request respectfully that there be some provision included under item 2, like a little 2, that requires the carriers to enter into timely single case agreements with a non-participating provider. That will at least provide some limitation, because again, already we have a network adequacy requirement that requires access to mental health and substance use disorder services non-urgent within 10 days. And if there isn't a provider available, the consumer is going to lose the opportunity to have that service provided within that 10-day period. So a timely single case agreement will enforce an existing right under our law.
I'm going to ask David, is there a definition of timely anywhere in the insurance code?
Not with respect to this. I mean, this particular law refers to, I think, unreasonable delay. So that's not defined. We've looked at that on kind of a case-by-case basis. But now that we have established network adequacy requirements that have specific standards, and one of those Ms. Weber just mentioned, if a company is not able to comply with those specific standards where we did set those, that would automatically not be considered not reasonable. That would be an unreasonable delay. But there can also be other situations that are not addressed by the specific standards we have, where it would still be, in addition, be considered an unreasonable delay. So there's not one specific broad definition for that term.
I see the commissioner's hand. Welcome, Commissioner.
Thank you. I agree with everything that David just said. I would just point out that the 10-day timeline sort of sets a guide. We can be more specific in our regulations, which we are in the middle of rewriting. But I would also note that sometimes what is unreasonable, particularly in the area of mental health, can be difficult, because the very point is when you are looking for oftentimes a very specific provider, and that person is not in the network and you need to find that person. So I would just say that I completely agree with both Ms. Weber and, of course, Associate Commissioner Cooney, that we can look at that 10-day time frame as a guide but it is necessarily going to be fact and circumstance specific.
Okay, so, and that is now, that 10-day timeline is in regulations now?
Yes, it
Or-
lays
or
out the time frame. Those
that you're
are
working
our
on.
standards.
Okay, all right, so, I mean, we could debate whether or not 10 days is the right number. But as you said, Commissioner, it is contingent on some difficult kinds of considerations, particularly around this group of providers. Ellen, you had something?
Oh, I'm sorry. I didn't put my hand down because I have a second point that I wanted to talk about, but you know, whether or not we define what that, I mean, to be able to set some parameters of timeliness does seem to be important, because it is what is essentially going to get us to the point of getting care for somebody. So it seems to me that even that particular standard sets some limits.
But it does exist already, or it will when the regulations are completed.
Well, it exists already, but it's not, again, it's not telling the carrier that they have to enter a single case agreement within that period of time. This would be a right that says we can look to what other standards are for timeliness, but they also have an obligation to enter into a timely agreement so that this is not a protracted negotiation.
I'm going to look to David or the commissioner to see if that 10-day standard applies to the single case agreement.
Well, not currently. I mean,
Okay.
our network adequacy standards look at that time frame, right, in terms of being able to access an in-network provider. So if you are not able to access an in-network provider within 10 days, I think what Ms. Weber is suggesting is that I'm not actually sure what she's suggesting. Then you get another 10 days to enter into a single case agreement. If someone isn't available within a 10-day period, and I'm not being, sarcastic here. I really am not understanding what that timeline looks like, because you need to find the person, identify the person, negotiate with the person, set a rate with the person, and
We lost your commissioner.
no, I was saying I
Oh.
just I wasn't sure what that 10-day time frame was intended to be. When does that run from?
Okay, I'm going to go back to Ellen since you're requesting it.
Quite frankly, I do not have a good response to you in terms of how that should run. I think timeliness means we are putting in a good faith effort to make this to enter into this agreement as quickly as we possibly can, because we have some considerations that are already in law. We're supposed to have access to this service within 10 days. So we're not sort of adding up additional 10-day periods, but we are saying that there is an effort that we need to sort of comply with what this standard is. And so I'm willing to have latitude. I'm not, but it does seem to me that there should be some obligation to do this quickly.
Okay. All right, I'm going to go to Dr. Berman and then to Laura Mitchell, and then we're going to wrap this part up. Dr. Berman. We can't hear you. You're on mute.
Thank you.
There
I apologize. Thank you. So just to add some information for the committee, and thank you, Delegate Cullison. I'm aware of many circumstances where developing single case agreements can take a month or more because of the negotiation process from carriers over single digits amounts of dollars. So that is the problem, that not only are people unable to find somebody in network, but then people can be nickeled and dimed, with all due respect, over a few dollars that can then lead to protracted negotiation.
Okay, so I'm going to take Laura and then I'm going to bring us back. Laura Mitchell.
Thank you. Yeah, I agree there needs to be some metric, because when you find that space, particularly with mental health and substance use, when you get that bed, you get that appointment, you can easily lose that and then you're waiting months longer. You go back to the bottom of the list. You don't stay as next on the list, and that may be too long.
So I'm going to bring us back to the language that says, let me find it. A carrier shall ensure that services received in accordance with the subsection for mental health or substance use are provided at no greater cost to the covered person than if the covered benefit were provided by the provider in the carrier's provider network. So I think, while we want this, what that language says is that when there is not an available provider in network, they will hold the consumer harmless. And that the single case agreement at that point, I mean, they're going to be working on the single case agreement, but they know they're holding the consumer harmless. And that's going to, I would think, motivate them to do the kind of negotiations we're looking at. So, and there is a timeline structure in the regulations. So I would like, unless there's a burning desire on the part of a member of the committee, to include the timeliness of creating a single case agreement, we can move on from there. Okay, I see no one coming up. So then the last one, so let me tell you, we've got one more amendment from our discussion this morning, and then the sponsor has provided me with some things that she wanted us to think about. And one is the report from the boards. And this is in the paper that Lisa sent out to us, saying the health occupation boards that regulate providers of mental health or substance abuse disorder services shall report back to finance and HGO on progress toward providing provider information to carriers for outreach purposes. So we're trying to, Delegate Kelly, we were trying to dance your dance. I'm not sure that we've got the right music here. If you have better words, we're open.
I think it sounds good to me. It does, nothing about that scares me.
That's good. Thank you. Ellen, is your hand up to respond to this?
No, Delegate Collison, it was to go back to the data point.
Okay. All right. So just to let folks know where we are now. And I think what I'd like to do is to vote on the changes that we've agreed to, and we can do them in pieces if people are more comfortable with that. So the first real change is on page 6, and we were accepting the language that we got this afternoon. Can I have a motion on the amendment that says inform members of the procedure to request a referral under paragraph 1 of the subsection?
Move the motion.
Okay, I got a motion for a second. Okay. Any further discussion?
Madam Chair, does that include the plain language in the right, or we still cross that out?
We still, in this language, we crossed it out. It's because it's consumer facing documents, which are written in ostensibly plain language as opposed to contract language. It wouldn't be contract.
So it covers it anyway. Okay,
Yeah.
thank you.
Yeah, thank you, Delegate. All right, those in favor, please say aye. Anyone opposed to this language? Any member of the committee opposed to this language? Please raise your hand. Okay, seeing no hands up, we're in agreement on that amendment. The next change we see is and I'm looking at handwritten page 7, and I'd like to do both parts of this. Number 2 and the strikeout of number 3. Can I have a motion on those amendments?
Move to accept.
Is there a second?
Second.
Okay, any further discussion? Seeing none, those in support, please say aye. Those opposed, please raise your hands. Okay, seeing none, those amendments are accepted. Then we are going to the addition of the report from the boards that says we'll get a report that says how they're doing on the work towards getting this information out. Can I have a motion on that amendment?
Move the amendment.
Second.
Moved and seconded. All those in favor say aye.
Aye.
Those opposed, raise your hand. Okay. All right. So now we have a couple of things that the sponsor has asked us to look at. Care manager. So the sponsor's asking that on page 5 of the bill, line 32. So now it's going to be the language that we have in from our amendment, to add the words "and to contact their carrier to request a care manager who will provide assistance with finding an appointment with a provider." So let me ask the carriers, do you have these care managers? I'm not seeing any carrier. Matt Celentano.
Sorry, I was trying to find my buttons. It is my understanding, I mean, I wouldn't necessarily say that there's care managers, but everybody has helplines in which they will get you on the phone and find that you have an appointment. I mean, there are care managers that work for the carriers, obviously, that will help you navigate, but I can't say that it would be uniform.
And Madam Chair,
Yes.
is it the wrong word? Should it be case manager? Is that applicable? And the reason I didn't get a chance to talk to all the carriers because it was just in the midst of all these meetings. Right. But in the effort to get to where we want to go is because consumers have called and asked for assistance, and I've been informed that they've just been pretty much given the same list that they've already called. And so that was kind of the level of assistance, and not like an individualized assistance to try to get to, where they need to go. That was kind of where it's coming from. And I don't know if it's case managers or care managers, but I'm just curious from the carrier's perspective, does that exist and is it doable?
Matt, do you have a thought? Or
I don't know if we need to codify calling the carrier, but we have always been encouraging folks to get in touch with the carrier to try to help. We want folks to call us if they're having issues navigating the system. I mean, that's sort of just boilerplate, but I see that Kaiser has their hand up too. I'd rather a specific carrier speak to this.
Okay. Let me go with Allison, because we've put Kim on the spot enough. Allison?
Yeah, we definitely have people that provide this service, although I'd want to see the specific language. I'm a little bit confused about where we are in this process. Is an amendment just been offered to put this language in?
Yes. You wouldn't have seen it yet because it just came to me from the sponsor.
Okay.
So
yeah, we certainly have people who provide this service, and as Matt said, we definitely want to help our members find care. So I just want to see the language to determine what the right person would be, or what the right term would be, and to see if we think that's something that would need to be in the statute or is something that's already existing.
Okay, I'm gonna go to Kim and then Deb, and then see if we can't get some good language here.
Thank you, Delegate Collison. So yes, there are staff who are care managers, there are staff who are case managers. This is outside of their role. They're really handling individuals with complex health conditions and are comprehensively managing their case. The individual who is looking for assistance in finding an appointment or finding an in-network provider who is not currently in a place where they need comprehensive management of their care is not going to come to a case manager or a care manager, and it really disrupts what the care management program looks like to take someone who is that kind of hands-on comprehensively for an individual to have this one-off task. I certainly get the delegate's concern. You know, if someone calls and just says, hey, I'm trying to find a provider, and maybe doesn't share that I've looked and was unable to find one on my own, why someone who just hears I'm trying to find a provider is going to assume, okay, maybe they haven't been in the directory, I'm going to send them the list, versus if the person, you know, again, through this education, and there's other education in the bill, to know to say, I've already made calls and been able to get an appointment, can you help me with that? I think helps the person on the other end understand what's being asked. But I don't know that I think we would want to name a role inside of our companies who also use different terms to do that.
Okay, Deb? Deb
thank you. I hope
Rifkin?
you all can. Hi, I hope you can hear me. I'm in my car, unfortunately. So similar to what Kim just said, we absolutely have a function within our company, and we actually have it in writing for our members to know to call us if they need help getting an appointment. However, it's not through care management, and we all call it something different, but we do have a process. And so I don't know, obviously, since unfortunately I'm driving, I cannot see the amendments, or, you know, I'm listening the best I can, but certainly if we would have an opportunity to look at it, I'm happy to think it through. I will say that that is essentially what all carriers through this whole process should be doing, because the goal is to make sure that you're not referring someone out of network. Remember, in order to follow the law, you have to meet the criteria that says you couldn't get an appointment in a timely fashion, or you couldn't find somebody within the expertise to meet the needs of the member. So they need to call you and say, hey, I can't find someone, and we try to find you someone by definition inside the network before we're going to do a referral. So I don't, number one, I want to think it through, because I don't know if that language is necessary, because I think it's innate to what we're trying to do.
I'm gonna offer that I don't think that person exists at this point. Perhaps it's something that we will have to look at going forward, but you know, we want the substance and core of this bill to move forward. So I'm hoping that we can wait on that. And is the Speaker Pro Tem still here?
Yeah, I'm still here.
Can you live with us holding off on that language? The care management language?
Yes, so right before I go ahead and say if I can live with it, but I just wanted to say this, that only reason why that was brought up is because there was and is and has been the complexity of the individual that needs the care, and they have been had advocates try to call and get this information. They've just been given the list, and that's pretty much it, because they've already exhausted the list, and that was the extent of the assistance from the particular carrier. So that's why I was looking at it a more individualized process, because the consumer really doesn't know the internal processes of the carriers, and so that's where I was trying to individualize it. And then to answer your question, my goal in this is where we're at the core of it to get what we need. And I think we've gotten that here in this bill. That question that I had regarding the care management or case management, I just need to explore that to see what it looked like and sounded like from the carrier. So thank you for listening and answering those questions. But I want to move forward with the core of our bill.
Thank you very much, Delegate. I appreciate that. Deb, your hand is up. Do you want it to still be up?
I
No,
think she's
sorry
right.
about that.
Okay, okay, that's all right. I know you're driving. Don't go looking at your phone while you're driving. Okay, I think that we are at the place where we have all of the amendments adopted that have been discussed. Do I have a motion on the bill as amended?
Move the bill. As
Okay,
amended.
do I have a second?
Second.
Okay, it's been moved and seconded. Any further discussion on this bill? Seeing none. Those in
What?
those in favor of the bill, please say aye. Those opposed, please raise your hand. Okay, this is unanimous. Good job, Delegate Sample Hughes. All right. Thank you.
Madam Chairman, your assistance is appreciated.
You're very welcome. All right, so we have one more bill. It is 7 o'clock. I would like to spend 20 minutes on this bill. I think, we're going to find in that 20 minutes that there are a lot of outstanding issues, and it's going to be problematic going forward. So given that, this is HB 1219, Pharmacists, Status as Healthcare Providers and Reimbursement. Lisa, you want to talk about it and talk about what the amendments do?
Okay, so this bill requires individual, group, or blanket health insurance policies and contracts delivered or issued delivery in the state by insurers, nonprofit health service plans, and health maintenance organizations, as well as Medicaid and MCHIP, to provide reimbursement parity for pharmacists. By January 1st, 2023, the Maryland Department of Health must obtain any necessary waivers to implement reimbursement parity for pharmacists for Medicaid and MCHIP. The bill alters the definition of healthcare provider to include a pharmacist and provisions of law relating to healthcare malpractice claims, maintenance and destruction of medical records, and HIV testing. There are amendments that strike the language related to the med-mal insurance, that specify the scope of practice of the pharmacist, that strike language related to HIV testing, that clarify that it clarifies the types of carriers that the coverage requirement applies to, that they cover these services already, and it moves the enactment date to January 1st, 2023.
Okay. So Delegate Bhandari, you want to speak to the bill a little bit more, or to the amendments?
Aaliyah, do you want to say a few words?
Okay, Aaliyah.
Sure. Hi, everyone. Good evening. I've been with you all day too, so I do appreciate the time and that you kept this on the schedule. This bill is really important to the pharmacy community for a variety of reasons, and I'm appreciative that the general consensus that I've gotten from the committee and from stakeholders is supporting the underlying tenets of this bill. So I'm very happy about that. For the most part, we are good with the amendments that have been presented in the document that was last sent out by Lisa. And that includes modifications from MedChi, as well as amendments from the health insurers. I understand that there's still some concern about the medical, basically the tort liability coverage. And I did want to speak to that a little bit. And I know this is not typically where this conversation takes place, but it is in the bill, and this is where the bill was referred to. I don't have any control over that. So this is where we are. And so the trial attorneys are seeking to remove the medical liability coverage from pharmacists that are included in this bill. And what I'll say is that there are 13 states that do include pharmacists with this type of coverage. Half of those are states that have the provider status that we're seeking. So this is not unusual. And what we're looking at with this bill is that it's enhancing opportunities for pharmacists to really focus, do more clinical services that are within scope of practice, and they do focus a lot on outcomes and standards of care. And if you look at case law in terms of medical liability and damages, when they're talking about the pharmacist's role, there is a broader scope that's being looked at beyond just dispensing. It is looking at standards of care. And I also wanted to mention that pharmacists and physicians have a corresponding responsibility to patients. And that is why we're concerned about the removal of that language. We've seen in cases where both the pharmacist and a physician are deemed liable for damages. The pharmacist and the physician either have the same amount of damages, or there are a number of cases where the physician has a cap on their damages because of their that medical liability ceiling or coverage, and the pharmacist has way more. And that has put pharmacists out of business. And we just think that with this bill, when we're looking at provider status parity, so to speak, that with physicians having this coverage and other healthcare providers and facilities where pharmacists are working, and we expect to see more engagement, those areas are covered. So when you look at the medical liability coverage that's in our current statute, it includes hospitals, medical daycare centers, hospice care programs, assisted living programs. We have a number of pharmacists, not a number, we have a practice of palliative care pharmacists. They work in these environments. It's very litigious. Those practice areas are covered. Physicians, osteopaths, registered and licensed practical nurses, dentists, podiatrists, and social workers, and even physical therapists. Pharmacists do work with all of these healthcare providers, and they do have that coverage. And it covers a wide variety of things with transitions of care, pain management, and as I mentioned, the palliative care, other types of consulting with medication therapy management. And so so the request and the language in the bill is not unusual. And so that's what I really wanted to make sure that the committee was clear on that. I know that, and honestly, I haven't had any conversation with the folks that want to remove this. The only communication that we had was outside of the Senate hearing, where basically we were told to remove it and that was it. So I don't know where there's an opportunity for modification here. So I think it's up to the committee and the bill sponsor to determine whether this is appropriate to keep it in here. We think it is, but I understand that we're trying to get this bill to move. But I think that is the major issue that we're at this point.
Okay. All right. Thank you, Aaliyah. So I see a couple of folks who want to respond. I'm going to start with Kathy Grayson.
Thank you, Madam Chair. And our comments are limited to the prior amendments that were referenced with respect to scope of practice that is reimbursable by carriers. So this is on page 10, handwritten.
You know what, Kathy, I'm going to ask you to hold this, because if I saw George Tolley come in earlier, I don't know if he is still here or not.
I think Josh Howell is also.
Josh, okay.
George, I might be wrong about that, but I think so.
I think George is still here. He may not be here, but he was in transit trying to.
I see
there
him.
He is.
All right. George, help. Can you?
He might not be able to
so
present
Josh,
our position, but I think he did want to let the committee know that he was available for any more like nuanced questions. I'm Josh Howe. I represent the Maryland Association for Justice. We're here respectfully asking the committee to maintain what's in the reprint, which is striking the section on the definition expansion under the Courts and Judicial Proceedings article. We assert that this has nothing to do with pharmacist reimbursement, which is the main purpose of this bill. And the whole purpose of the Healthcare Malpractice Claims Act, which this definition a pharmacist is being added to, was developed in response to a crisis regarding doctors being able to afford medical malpractice insurance. And it was designed with very discrete goals in mind. And we would maintain that the pharmacists haven't really proved that there is an issue with maintaining liability insurance, so that we just don't believe that this expansion of the definition is appropriate for what this bill is trying to do, which is make sure that pharmacists are being reimbursed appropriately.
Okay, thank you, Josh. Delegate Bandari.
Thank you, Madam Chair. I would, as a sponsor, I would accept striking that judiciary proceeding thing. And I know it is very important, this tort liability and medical liability thing. I think we could do it next year, but I would accept the amendment.
Okay. Unless there's opposition from the committee, we'll allow the sponsor to accept that amendment. Is that good with everyone? Okay. Then now I'm going to go to Kathy Grayson.
Thanks very much, Madam Chair. So I'll go back to the initial amendments that Ms. Horton referenced, and CARE First had sent some preliminary language, and then subsequently had the chance to talk it through with our league members, Matt Chalentano's group, and some other carriers. So there are a couple outstanding tweaks that I don't think there is yet a meeting of the minds. So I'm on the handwritten page 15 of the reprint that Lisa shared this morning. And I'm looking at lines 6 through 9. The most critical change that we think is needed to the bill is in section B here, where it says an entity subject to this section shall provide coverage for services rendered in any setting. And let me tell you why in any setting is a problem for us. So if you think about, as we see pharmacists start to include certain medical skill sets in their scope of practice, where they just traditionally have done pharmacy skill sets. So examples would be administration of vaccines, administration of maintenance injectables, like this body passed recently. Those are billed through what's known as the carrier's medical benefit, not our pharmacy benefit. And so that comes through CARE First, not our PBM to pay. And we've been able to operationalize that. If we're talking about traditional pharmacy benefits, though, that all flows through a carrier's PBM. And why does that matter? Because in the carrier medical space, we have our providers credentialed and in networks as a general rule. So we start to think about these practices broadly applied. This bill is going to allow pharmacists to perform to the full breadth of their license, which we are okay with. If it's a covered services, we're okay with reimbursing it, whether it's done by a pharmacist or whether it's done by another licensed provider. But when you do it in any setting, it starts to beg questions about impact on our members. So today, even on our medical benefit side, we do credential pharmacies. So if you do a maintenance injectable administration at the Rite Aid that you work at, you can bill us for that, and it's done through the pharmacy. At the hearing, there was discussion about these services being done in other settings. For example, pharmacists that are employed by nursing facilities or other external entities, and just maybe even doing it as an independent contractor to supplement services in medical facilities. The pharmacists are not credentialed independently with us, and so we do not have a way to operationalize that. And what does that mean for our member? It means that the rate that the member will be charged is either going to be the PPO rate out of network, which is high, or if it's an HMO, it won't be covered at all. And so the member could be balance billed for the administration of a certain medical service outside the pharmacy setting. So we really feel that this in any setting language needs to be stricken. And as we go forward, thinking about the breadth in which pharmacists wish to practice, we need to think through what that looks like from a credentialing perspective, because our main concern is that our members will end up obtaining those services. So that's the first piece. Did you want to discuss that, Delegate Cullison, or should I keep going?
Yeah, let's discuss this part first. Just write down so you don't forget what point 2 is. Aaliyah, did you want to respond?
Yes. So I just wanted to be clear with pharmacists seeking this provider status and what we're calling health pay healthcare provider equity, there is a full understanding that pharmacists would need to go through a credentialing process. We're not asking for anything different than any other healthcare provider would have to do to bill on the medical side for those additional services. What we wanted to make sure that was that this was focused on the pharmacist, and that this is a pharmacist bill, not pharmacy, and that they could apply for their credentialing to be added to a network regardless of where they practice. If that is covered, if that is fundamentally understood and covered, I'm fine with taking out the any setting. We just wanted to make sure that it wasn't going to be limited to, only pharmacists in, if they're only working in the pharmacy, or if they're only working in a hospital system or something like that. We just wanted that flexibility because we don't believe that, we just didn't want limits on it. I'll just put it that way. But you're right. What we are looking at is through the medical billing side, not the pharmacy benefit, not through the PBMs. And so I don't know if you guys had that same understanding. If that's the case, then I would be fine with eliminating that language.
So I'm going to go to Allison and then back to Kathy.
I don't know if it applies to Kaiser though, honestly.
Yeah, well, so that sort of got to my point. The way I was reading this language was potentially expanding almost like an any willing provider type thing which I talked to Aaliyah, it sounds like that's not the intent. My concern was it's still kind of read that way. I think what she's describing is what we would already do wherever the pharmacist is working. There wouldn't be a limitation if they're in a hospital setting or in a private practice or whatever. So from my perspective, I don't think that language adds anything. My concern is it could be construed differently. So I would suggest taking it out.
Kathy, do you have another comment on that? Because I have a question if not.
Go ahead with your question, Delegate.
So, and I guess I think this is for Aaliyah or maybe for you, Kathy, or one of the carriers. Are there situations now where individual pharmacists are credentialed by a carrier?
I can speak for Care First. It's my understanding that is not a regular practice today. As I mentioned, the other services that are being performed now under the medical benefit, I'm told the pharmacy is who's credentialed, which is not to say that we wouldn't be open to going through that process with pharmacists in the future. It's just not the way it's done today. So that's what sort of threw us off with the concept of any setting.
Okay.
That's interesting because the feedback that I got when we were working on this bill was that pharmacists need to understand that credentialing and the payment for services would not go through pharmacies, that it would have to be individual pharmacists and that they would have to go through a credentialing process. That is the case in other states where this provider status and healthcare provider equity has taken place, is that pharmacists do go through a credentialing process and they're treated like any other healthcare provider in that sense. So what was explained to me is that a physician that's working in a group practice, the group practice is not credentialed, it's the individual physician that's credentialed within the network. And that would be the same expectation that we would have.
Yeah, and if I could clarify for Aaliyah, this is how we do it today for the limited services that pharmacists are allowed to perform under health acts that are, part of what we're required to pay for. With this bill, expanding that to include the full breadth of everything you all do under health ops and requiring reimbursement, I think that's where the change would come. There would need to be an individual pharmacist credentialing in order for us to reimburse at that broad level.
And that's our understanding. Okay. We're not trying to shirk away. I mean, like I said, they are fully aware of what this means and what the additional steps would be to make this happen. But we've needed to get it in statute so that this would happen. Otherwise, it's not moving in that direction.
Madam Chair, may I ask Aaliyah one more question?
Sure.
So how do you envision, Aaliyah, working for from the member perspective? So let's say that you have a pharmacist that gets credentialed just like any other medical provider, and they're performing these services. Is there an opportunity where you look at whether you're in a network before rendering the service to a member? I'm just trying to understand how you all envision that being stood up.
I think we have to work through that process, and I think that's going to be up to them on how they do that. There are a number of services that pharmacists provide now that they charge a fee for, where the patient has to pay up front because they're not getting reimbursed by the patient's health insurance. And so I think there would be a process just like any other healthcare provider where that would work. And it would be up to them to make sure that people knew which networks they were in and that sort of thing. I haven't gone through the details of that with each individual pharmacist and how they're going to handle it. But I will say we have a concurrent process going on with decision makers within the carriers to talk about how to operationalize these programs, how to focus on areas that the carriers think pharmacists could have a greater impact to improve some of the star ratings and those other things that need to happen. So this is a parallel process, and there's understanding that this bill passes and every single pharmacist is not going to be able to go out and bill. There are steps that they have to take, and we understand that there are steps that we need to work with the carriers, but it's not within this bill. It's operationalizing that. We have a full group of the Maryland Pharmacy Coalition that is working with the carriers in doing that in a different, like I said, in a parallel effort.
Okay, I see Kim Robinson and Allison Taylor. Matt took his hand out. Oh, and he put it back up. So Kim, you want to speak to this? I think what we're speaking about is the credentialing piece. And Kim, you operate outside of Maryland. Can you describe how pharmacists might be credentialed in other states to provide this medical benefit, basically?
Yeah, so this is going to echo something that Kathy just said. Today, the scope of services that pharmacists are allowed to provide under their scope of service or scope of license are still fairly narrow from a medical perspective. And so a lot of them are being delivered still at the pharmacy level and not the individual pharmacist being credentialed level at this current time. One, because it's hard to operationalize, and two, it hasn't necessarily warranted it. It was a little bit more of a tighter connection when we were talking, vaccines, or even maintenance injectables, where it was administering the drug was what was happening. I think what you're hearing from Ms. Grayson and myself, as we're hearing now, I think I'm getting a slightly broader vision for what this bill is trying to accomplish, is that there's a whole lot that comes with moving on to a medical panel that I think now are suddenly open questions. For instance, how do we deal with the fact that Maryland's law requires we list all of our credentialed providers in our directory and we're not allowed to suppress them? So a pharmacist who has this very narrow scope of medical service that they're able to provide, there's not a designation to limit that for patients who sort of see them in the directory and under what capacity. I don't know that the general public will understand that this is the scope of medical practice for the pharmacist. So I feel like there's a lot that comes along with getting on a medical panel that is also rooted in law that now gets triggered if the expectation is not the way I sort of originally envisioned the bill, which was much more pharmacists in what to my mind was a more traditional setting, the pharmacist in the pharmacy, the pharmacist in the hospital, but now expanding to pharmacists in other settings, providing services in other ways. Are they independently providing these services? Are they providing them through the facility? The way we've done it in the past is they're providing it through the hospital, they're providing it through the pharmacy. So if we're now treating them as individual practitioners, are they individual practitioners, or they still have to be tied to another facility? And are they now billing separate from the original sort of place where they were housed? I guess is a question I hadn't contemplated previously.
If I could respond to that, I thought we were pretty clear and that's what we were looking for. There are a host of CPT codes that pharmacists can bill to. I don't want to put CPT codes into statute, but we're not expecting pharmacists to go set up a physician's practice. That's not anything like we're trying to do. But it is an opportunity, yes, for pharmacists to provide and work within their scope of practice to provide services that benefit patients in Maryland. And they benefit the other medical providers that are working. And we think it benefits all of the health insurers in terms of reducing their costs with recidivism rates to the hospital and all of that. I don't know, like I said, I would be fine with taking out in any setting if there's an understanding, if there's no limitation in the bill that these individual providers can't be set up. Now, you all can set up whatever system you want to, but this would allow the pharmacist to be able to access those networks and to I don't know what the process is to sign up and seek to be added to the networks. That's really what we're looking for.
Let me ask. Currently, Aaliyah, I just heard you say there are some CPT codes that you bill now from a pharmacy. Is that right?
They're eligible to, there are a few, but they're eligible to their specific CPT codes that were developed for pharmacist administered patient care services. And then there are some that are some general consulting therapy management CPT codes that are used around the country in those states that do have this provider status. So it's established. We're not asking for the development of new ones. This is there. They're available to be billed. I had agreed to move the effective date of the bill to and agreed to what the carriers asked for in terms of having more time to implement the process. And it may take more time. We can get that effective date in, but it may take time to implement this. We're not arguing with that. And it is a change. It's a change in process. And that's why we brought forth this bill. And I think there was a misunderstanding when I brought it. Everybody said, well, why are you doing this? You don't need to. But now that we've got it here and we're at this point, it's kind of like, hold on. But we've been very clear on what our intent was with this bill.
Okay, I'm going to go to Allison and then Matt, and then back to Kathy. And then we're going to wrap it up for the evening.
Okay, real quick, I just also wanted to point out that this in any setting language is also in the Medicaid statute. And in the spirit of consistency, I'd suggest if we're interested in taking it out in the commercial setting, maybe do that there as well. KP, I'm not going to speak for Care First, but both of us operate as MCOs and as carriers. So would want to sort of see a parallel thing and a parallel understanding going on between Medicaid and commercial in this setting.
So I'm confused in if this would be allowed, why would the setting matter for a pharmacist to operate within their scope of practice to deliver services to the beneficiaries? Why would the setting matter if they're within full scope and they're following statute, they're following all the requirements, reporting requirements, anything that's needed and in the law that they would have to follow to meet their obligations? Why would the setting matter?
I think, Aaliyah, I think the piece that's been missing, at least from my perspective, is I didn't understand the single pharmacist credentialing requirement that would be required under what's being asked for here. And the fact that, that folks that currently it is the pharmacy that is credentialed. So I think that's why that's why the setting matters, because we weren't, at least I can't speak for the carriers, but I was not envisioning this this individual credentialing.
The reason why I bring it up is because as you saw in the testimony, that we had federally qualified health centers, and maybe this doesn't apply to the private carriers. That part I don't know, but like the federally qualified health centers supported this bill. And it's because we have these different practice settings where pharmacists are working and providing care, but the actual entity can't get reimbursement for the services the pharmacist is providing, and they can't expand those services. And whether that's in MedStar, the federally qualified health centers, and other practice settings. And so if we need to talk about how they're reimbursed, so do we need to say it's only in these settings that the pharmacist would be reimbursed? Like, would they be, I guess I'm confused on where it would happen. Only in the pharmacy?
If they were individually credentialed,
Mm-hmm.
then it could happen in, you don't need in any setting because it would be
right.
And
I'm fine with that.
And I think, like I said, that was the piece that was missing. Okay, I'm going to go to Matt and back to Kathy, and then, like I said, we're going to wrap it up for tonight. Matt.
Thank you, Madam Chair. It might just be that it's 7:30 or I'm an idiot or both, but I'm a little more confused now than I was before. And Aaliyah, you had mentioned that you're already working with carriers in Maryland on this. Could you explain a little more about that? Because I'm not sure.
There's a task force, so it's not me specifically. There's a Maryland Pharmacy Coalition task force that is working with other carriers that they've identified to see where they are specifically said they're working with the decision makers. So they're not working with the lobbyists. I'm just going to put that out there. They're not working with lobbyists. They're working with people within the companies to look at what their healthcare goals are and how to operationalize this process so that pharmacists can provide these services that will help them with their individual goals for the different patient populations. So they're trying to do some targeted work, but we don't feel that this targeted work needs to be specified in the statute. The private entities can work that out. I do want to just bring it back to, if we remove in any setting, I would like the carriers to explain to me what that would mean for the pharmacist. So if I were to say, yes, let's remove in any setting, what does that mean for my pharmacists that are trying to provide services? I'm sorry, Delegate Collison, if I may, if I may.
Sure. So Kathy, you want to take it, or Kim?
Sure, I can take a crack at it. I mean, I think, Aaliyah, just the way that we literally read in any setting as written, as Allison, I think, alluded to, it could be read as any willing pharmacy, any willing, provider. So I don't think that was your intent. So that was the primary reason we wanted to strike it. In terms of what it would mean for places that a pharmacist can render services, I think the piece that was missing for me, it was the same one that was missing for Delegate Collison. I didn't really understand until we're having this discussion now that your goal is really to create a more robust path to medical credentialing for pharmacists. And if they're credentialed, then they should be able to provide the services wherever they're credentialed to provide them. It's just today we don't have a lot of pharmacists. I don't think we have any pharmacists. I can double check that are medically credentialed. It's all coming through the pharmacy, and so that's
the
where
point of the bill, right?
Now, so now I understand what you're trying to do here. And if there's a runway for implementation, I'll take it back to my folks, and I think we can make it work if we take out in any setting. There was one other tweak that I know Care First needs.
What's that second piece? Right.
Sure. B2, it says the services are within the scope of licensed pharmacists. We would like it to say the covered services, just as sort of a belt and suspenders approach that we're covering within the terms of our contract. It's not a mandate, to cover outside of what's in the contract. So that would be our only request.
Okay.
Contract with the I'm sorry.
So that's in line 14 on handwritten page 15, right? And that's so it would just say the covered services. So whatever,
you have this.
Right. Okay. So here's where we are on this bill. We've discovered that it's bigger than we thought. And so we need to work out how to address the notion of individually credentialing pharmacists in the bill. It's not there yet. Because I hope I wouldn't have missed it if it was there. So can we work? I mean, if some folks can work on this, see if we can get to some language that might work. I mean, and Steve, do you guys have a thought on this? You understand that if the pharmacists are credentialed, then they provide within their scope of practice wherever they practice as a pharmacist.
That was all very educational to me this evening.
Okay. Yeah.
Because I, like you, Delegate Carlson, didn't see anything about individual credentialing and medical panels and things like that.
If I could say, when I approached the insurers about this, the feedback I got was, you understand the pharmacists will have to be individually credentialed. And so I took that back to my members and they said yes. So this conversation about not knowing that is really new to me, because this was what was given back to me and my members agreed to that. If there's an opportunity for pharmacists to rephrase that, I would like to work on this because I think this is an important bill, but I am very taken aback, honestly, because this is the information that was given to me from the carriers, that the pharmacists would have to be individually credentialed.
Okay.
And so for everyone to say that this is brand new, I feel is a little disingenuous.
Okay. And I am going to let the sponsor have the final word on the bill for tonight.
Yeah, thank you, Madam Chair. I will absolutely go with your wisdom. So I'm wondering if we could pass other amendment and come back, or just have a language and move forward with the bill.
And the language, absolutely. What I'm suggesting is that there be language that specifically refers to a pharmacist being individually credentialed. And be able to practice within the scope of their practice in the setting in which they work.
I love the language. I would like to move the amendment.
I think there needs to be a little more tweaking of it. It's not.
I just have one question, if that's okay. Do other healthcare providers in their scope of practice law, does it say that they have to be individually credentialed?
They all, I am going to look to a carrier.
In the statute, does it say they have to be credentialed? That's my question.
Yeah, I can look. I'm not aware of the exact statutory requirements, Aaliyah, but it's my understanding we pay claims to credentialed providers that submit claims. So you have to be credentialed to get paid. I mean, we're not just going to pay someone without verifying their education and et cetera.
Right, but is in the statute as you're requesting that to be, or where this conversation is going. We're looking for parity and equity as healthcare providers, and to add that additional, to put credentialing in the statute puts it in a different realm. I'm just trying to find out if that's what everybody else has to do as well.
But it is different, Aaliyah, because right now pharmacists are not individually credentialed. Their institution is credentialed with the knowledge that they are licensed pharmacists. So that's what is different in the insurance world for pharmacists. So we are asking for something different than, than another kind of provider, where it's actually the provider themselves who is credentialed within the insurance world, as opposed to for example, I go to physical therapy to a group. Each of those individual therapists has credentials with my insurance company, at least the ones I see, and but the organization itself is not credentialed. Am I saying that correctly, Kim?
Thank you, Delegate Collison. You are. I think there's two different ways this happens. Facilities can be credentialed, and then the staff at facility is billed under the facility.
Hit the little search
So
button, type
ironically,
camera.
pharmacy, right? So if you think of pharmacy where the individual pharmacist is not being credentialed for the individual work that they're doing, the pharmacy is being credentialed, and that's who's filing all the claims and getting paid. Or it'll be a practice group where the individual providers in the practice group are only billing for the patients that they see. So there are two different ways that happen.
Okay.
And this is shifting from the first, which is how pharmacies are currently being reimbursed, to the second. So I think that's what's happening in this conversation.
Right. Okay.
Yes.
All right. So Delegate Bandari, you've got until Thursday to figure out if there's a way forward here. I heard Kathy Grayson say, well, we can work on this. So she might be a good resource on this. Aaliyah, if you guys want to sit down sometime, or not, maybe not sit down, but, you know, sit in your respective locations, remote locations, and have this discussion about how the language.
I'm happy to do that. It benefits everybody.
Yep.
I'm
Okay.
happy to do that.
I want to thank you all for your patience and indulgence in this. And, you know, you all are familiar enough to know what crossover week is like. So I'm looking forward to coming up for air next week, sometime after Monday. So thank you all. With that, we are adjourned for the evening.